Welcome everyone to our Healthcare Data Matters webinar, where healthcare leaders and innovators join in conversation to set a new standard of patient-centered and data-driven care. It's my pleasure to announce that this is the kickoff of season 2 of this series, and we wanted to thank everyone for your support. Today's topic discusses a new way to assess energy expenditure without metabolic cart using VC02 data. Before we meet our guest, Patricia Brown, let's do a little housekeeping. First off, my name is Bruce Hall, and it's my privilege to be your host for this webinar and related podcast series. Let's cover a few disclosures next. First, funding for the Healthcare Data Matters Forum is supported in part by Medical Informatics Corp and Intel. Presenters' opinions and viewpoints are their own, and we do not pay speakers or offer any exchange for product endorsements. You can see other disclosures on this slide. Now it's my pleasure to introduce our guest today, Patricia Brown. Ms. Brown is a clinical dietitian specialist at the Johns Hopkins Hospital. How are you doing today, Patricia?
I'm doing well, Bruce. Thank you.
Great to have you with us. I understand you go by Trish. May I call you Trish?
Absolutely, yes.
Okay, very good. Trish, our format today is first, I'll ask you some questions to give you the chance to present your work to our audience. And during our talk, audience members can type any questions they may have in the Q&A tab as shown on this slide. At the end, we'll address as many questions as we have time for from MIC VP Raj Patel. Sound good?
Sounds great.
Okay, great. Let's dive right into our topic. And first off, Trish, can you tell us a little bit about energy expenditure, why it matters, and the current recommended method for calculating it?
Yes, Bruce. So these patients that are critically ill are not able to eat on their own. They're on the ventilator. And so we're feeding them with an infusion, either enteral or parenteral. So knowing the actual caloric needs of the patients is really important because, well, nutrition is important and it can affect their outcomes. Aspen and SCCM recommend use of a metabolic cart, which is a equipment that we use to measure indirect calorimetry. If you don't have indirect calorimetry, then it's recommended that we use predictive equations, or 25 calories per kilogram to 30 calories per kilogram, and that's adjusted based on their BMI. Next slide. This is the picture of a metabolic cart. Really what happens with the metabolic cart is the volume of carbon dioxide that a patient expires out of the ventilator and the amount of oxygen that a patient inspires from the ventilator is measured. That gives us something called a respiratory quotient. A respiratory quotient is simply the volume of carbon dioxide divided by the volume of oxygen. With these data points, we can come up with an individualized caloric need for each patient in the moment in time. It's different than the predictive equations, which are very generalized. Predictive equations are not specific to the patient, and they're not as accurate. Next slide. The problem is that many institutions don't have a metabolic cart to get these data points. And so they have to rely on the predictive equations, which may or may not be very accurate. In addition, if an institution does have a metabolic cart, it can take about an hour sometimes, depending on the calibration of the machine, to do one of these procedures to get the VC02 and the O2 data. And so staffing is an issue. Sometimes you can have a metabolic cart and it's sitting in a room somewhere unused because staff is a problem.
So we have staffing issues. It takes a long time to capture this data using the metabolic cart. You're clearly looking to, it's clearly an important measurement, this resting energy expenditure. Based on the manual and time-intensive nature of this process, is there an alternative that's being recommended?
Well, great question. So around 2015, an interesting study in the next slide tried to answer a question. Now, if we need the volume of carbon dioxide and the volume of oxygen, and we get a respiratory quotient, algebraically, they thought, well, if we only know some of these data points, maybe we can substitute it and come up with a way to take these data points and put it into what we'll talk a little bit more about in the next few slides, but the Weir equation. And that Weir equation will give us the energy expenditure. So in this study, there were two subsets of patients, both actually children, And they did an indirect calorimetry using a delta track 2, which is the gold standard. And they measured indirect calorimetry on each individual patient, which gave you a respiratory quotient for each individual patient. With a second subset of patients, they did indirect calorimetry, but they just pulled out the volume of carbon dioxide data from that. So then they took the respiratory quotients from all the patients in the first set and they averaged them. Then they just put it all in algebra. They substituted volume of oxygen for volume of carbon dioxide divided by this respiratory quotient and put that into the Weir equation, then measured it all against the delta track 2 again to see if it was at all close to indirect calorimetry. And surprisingly, it came out to be very close. This new equation and new way of doing this was not only closer, it was close to indirect calorimetry, it was more accurate than the predictive equations. Next slide. To follow up with that, since that was done on children, around the same time, another study group looked at adult critically ill ICU patients, med-surg group, with an Apache score of about a 24, which is a pretty sick patient population. They did indirect calorimetry on all the patients, and then they did a simultaneous volume of carbon dioxide only that was generated from the ventilator. So then they actually, for their RQ, they did something a little bit different. They used what they called a nutritional RQ. And what that is looking at all the infusions, all the nutritional infusions that the patient was given, enteral, parenteral, propofol, and IV fluids, and came up with an RQ that way. If you're interested in knowing how to do that, you can look at this study. It's not really difficult, it just takes a minute. But they used that RQ, and it came out to be on average about a 0.6. They put all of that algebraically into the Weir equation and found out that that was probably within about 10% accuracy to an indirect calorimetry done by the delta track 2 metabolic cart. So really good results. And then in addition, it was more accurate than the 4 different predictive equations that they looked at it against. In the next slide, this just kind of discusses a little bit about the fact that a nutritional RQ may not be the most accurate, because when you're critically ill, your body's not, the substrate that the body is burning for nutrition or for metabolism is not only what we're giving to you exogenously. It's also what you break down when you're, quite often fasting. You can't feed some of these people some of the time. And so the breakdown of their own muscle stores or their own fat plays a role into the substrate that's burned for metabolism. But as I mentioned from the other slide, the average RQ for the nutritional RQ is like 0.86. In this study, they suggest using a 0.85.
So you're leveraging the volume of CO2 method, but talking more about RQ, I understand you looked more closely to figure out which was the most accurate RQ to use and to see if there was some way to automate this calculation. Can you tell us more about that?
Sure. With the next slide. At our institution, we looked at exactly what you said. We tried 3 different RQs to see which might be the more accurate. We tried 0.85, we tried a nutritional RQ, and we tried the 0.8. We found statistically that the 0.8 was a little more accurate for us, but this was a very small subset of patients, and we're still collecting data on it. If you look back at the study that the reference from the previous study, you'll find that really anything between like 0.79 and maybe almost 0.89, anything you use RQ wise in that sort of range is going to be pretty accurate and pretty close to indirect calorimetry and likely more accurate than the predictive equations. Next slide.
And I understand you actually have the equation here on the next slide, right?
Yes. This is just to show you what I've been talking about. So the abbreviated Weir equation on the top there is what you would use if you had a metabolic cart and you were able to do indirect calorimetry and had the data points of the volume of oxygen, the VO2, and the volume of carbon dioxide, the VC02. All this new equation really does is substitute the volume of oxygen with the volume of carbon dioxide divided by the RQ. And that can give you the resting energy expenditure, which is the actual caloric needs for a critically ill patient in that moment of time. It's really great because you can do it every day. You can do it several times a day if you wanted to. But it's so much better and easier than doing indirect calorimetry, which you really rarely would do daily. And then if you don't have a metabolic cart, you can't do it at all.
So again, we don't need the metabolic cart. This comes right off the ventilator, right? How does that data come off the ventilator, and how do you actually view it?
Okay, great question. So you can get this data downloaded off the ventilator on a flash drive, but on the next slide, I can show you that we at our institution use sickbay. And sickbay is great because it will project waveforms. As you see here, this end tidal CO2 is really what happens when the respiratory therapist just adds a piece, an end tidal piece to the ventilator. We get this waveform that shows us the end tidal CO2, and that's the measurement of carbon dioxide coming out of the patient. Next slide. As you can see with that red arrow, I'm pointing to the fact that we're looking at the CO2 minute production in mLs per minute. So we can see how much carbon dioxide the patient is expiring. And in the next slide, you can see the red arrow is pointing to an export data spot where you can just export that. And in minutes, I have the VC02 data. Depending on whatever RQ number I use, I can have a resting energy expenditure within minutes with no extra staffing.
And Trish, my understanding is by having this data, the energy expenditure, you can drive the exact nutrition levels that a particular patient needs. Is that right?
Well, that's exactly right. Yes, you get the actual individualized caloric needs for that patient. And these critically ill patients, they can change rapidly. They can become septic or have other changes that happen along the way. In the initial part of their phase, they may need very few calories. And then as they're recovering, they need a lot more calories because they're anabolic. So it's really important to know the changes as you go along. And this new equation gives you that ability to know that on a daily basis.
Well, that's great. You can see this visually, and this is on basically a web page, right? So anyone with the right access can view this from anywhere. Is that right?
Correct. Actually, in North Carolina, I can see it. If I'm in the institution, I can see it. Anybody that has access can see it.
Wow, that's great. And some impressive results here, Trish. What do you envision as the next steps of this process?
Well, at the very minimum, this would allow every RD or any healthcare provider that was interested to know the resting energy expenditure or the caloric needs of every patient. But what I would be really excited about seeing someday is to have an actual waveform that calculates this, and you can see the resting energy expenditure needs. So practically that might be helpful for the nurse who's at the bedside, who sees, oh, wow, this patient needs 2,000 calories today. And I'm only been able to get in about 500 so far due to NPO for procedures or something along those lines. But they would be able to see in every moment of time what's happening, the changes that are happening from a metabolic rate standpoint, and be able to address it. In addition, perhaps someday with sickbay, we could upload some lab data, which also might be helpful for other types of energy expenditure with ECMO patients.
And pull that all together. So really impressive work, Trish. And boy, to take something that takes an hour and make it possible to be essentially instantaneous or possible at all if they don't have a metabolic cart, some really impressive results. So congratulations on that.
Thank you.
Thanks so much for explaining your work to us. I do see we have some questions coming in the Q&A tab. I'm going to turn it over to Raj Patel, who is the manager of development at MIC. Raj, are you there?
Hi, Bruce. Can you hear me?
Yes, I can. Take it away.
Great. Right. So as Bruce was saying, if you have questions, please click on the button near the bottom middle of your screen and type in your question, and I'll ask them as they come in. We might not get to all the questions, and if we don't, that's okay. We're still going to pass them on to Trish, and so she can answer them, and y'all can stay in contact. So the first question that I have for you, you discussed the exact, caloric needs of a patient, overfeeding and underfeeding being things to avoid. What are the risks of overfeeding or underfeeding patients?
Okay, so great question. Well, nutrition is important because if you don't have the correct substrates, the right protein and calories, you may not heal your wounds correctly or adequately. In addition, the diaphragm is a muscle. So if you don't have enough calories, the diaphragm can wither away, so to speak, and you won't be able to possibly get off the ventilator as we would like you to. In addition, it can be related to immunosuppression. And on the flip side of that, overfeeding sometimes can cause you to have the inability to get off the ventilator because you're producing potentially too much CO2. So there really is a sweet spot that you want to meet.
Okay, yeah. It seems like you want to stay right in the middle there, right? Not one way or the other for a variety of reasons.
Correct.
Are there any patients that you can't use this technique on, or for whom this technique doesn't apply?
Right. So some of the slides that I showed you in those studies, they did not include some of the patients who had ventilator settings that would be out of range for a metabolic cart to be done because they were measuring things against indirect calorimetry. And that sometimes can be different settings, FiO2 and PEEP, that you have to be careful of. But the beauty of this ability to have just the VC02 data, I think we can do it on every patient without those settings being a problem. However, in the same way that you couldn't do a metabolic cart on somebody who has, say, a bronchopleural fistula or a trach leak, or somehow that you're not capturing all the oxygen or CO2, that would be the same reason that you wouldn't be able to use this for those patients.
Got it. Now this question has come in, and I'm not clinical, so forgive me if I get these abbreviations incorrect. The question is, would a PT on CRRT or HD alter the result of this equation?
Oh, that's a really good question. And I'm not sure we have enough data yet to know that. We have looked at some of our patients on CVVHD and off, to see if it was a difference. And there was a slight difference, but it was less than I thought. That's a really good study that I hope somebody does, because there could be a change. But we pretty much just use the data as it comes in, because it's pretty close. If not 100% accurate, it's a pretty close estimation.
All right. Very good. We can keep the line open for a couple more seconds if there's any other questions coming through. All right. I think that's a good place to then pass it back off to Bruce if you're there. Bruce?
Yeah, I saw something in the chat here, Raj, if perhaps Trish could explain that question. I know there were acronyms that I had no idea. I think I can speak for you as well. Maybe explain to more of the uninitiated what you meant by those various acronyms that you were talking about in your last answer.
Sure, be glad to. So they were saying if patients have renal failure and they're on continuous venous, continuous renal replacement therapy or intermittent renal replacement therapy, would the caloric needs be different, I think, or would this still be able to be utilized? In the same way that a metabolic cart can be used while somebody's on renal replacement therapy, the VC02 data would be as accurate or as indicated. So I don't think, so I believe that if you have renal failure, this equation still works.
Okay. I'm going to take host's license here and ask you a question that I hope is not completely out of left field. When you use the word ventilator, I think of COVID, because obviously so many more patients have been subjected to ventilators because of the breathing issues that COVID obviously brings along. How has that impacted your work? Has it made you accelerate your work? Has it given it more focus or more of a spotlight? What are your thoughts on that?
It's a good question. Yeah, we are, it's a different population. It's a brand new disease, and it's a different patient population. And it's been really helpful to be able to use this data, because we don't have the ability to have indirect calorimetry on every patient. And these patients do change really quickly. They're really highly inflamed. We can see really large caloric needs at the later stage of their disease and lower needs initially, but they seem to change fairly rapidly. Plus they tend to get septic or have other things that come along that affect their metabolism. And then really interesting is that we're working a lot with the ECMO patients, the COVID ECMO patients, and As their lungs start to contribute to and begin to work, we can use this data to kind of compile the metabolic rate that we have. We have a way of figuring out the ECMO caloric needs based on blood gases, but then when their lungs are opening up, this VC02 data that we can see on sick bay really helps us to make it a full picture.
Well, that's great. Thank you. And it's all you hear about these days. And thanks for drawing that parallel there. So any other questions come in, Raj?
Nope, I think we're all set.
Okay, very good. Thank you again, Trish, for joining us today and sharing all this great info with us.
Great. Thank you so much for having me.
Yeah, it's been wonderful. And to the audience members, a replay of this webinar will be available on healthcaredatamatters.com and a podcast version on our Healthcare Data Matters podcast channel. While on that site, you can also check out our previous webinars and join the conversation on our associated social media channels. Before everybody signs off, would you please, as we close the session, you'll see a short 5-question survey pop up. We'd really appreciate you staying for one more minute to complete it, as it helps us to continually improve the content of this webinar series and give us ideas for other topics you might be interested in. We'll also be in touch with information on our next Healthcare Data Matters webinar. Thanks again for joining us, everyone. Here at Healthcare Data Matters, we are grateful to have the opportunity to advance a new standard of patient-centered and data-driven care. Take care, everyone, and enjoy the rest of your day.